ARDS. ARDS, the expansion is Acute Respiratory Distress Syndrome. This syndrome, it is characterized by sudden progressive pulmonary edema, increased bilateral infiltrate on chest X-ray, hypoxemia, refractory to O2 supplementation, and decreased lung compliance. So, in acute respiratory syndrome, what happens is there will be progressive pulmonary edema and increased bilateral infiltration, and there will be hypoxemia, that means impaired gas exchange occurs. In this picture you can see normal alveoli and there is adequate oxygen exchange, oxygen and carbon dioxide exchange. But in the ARDS alveoli, here what happens is there is fluid accumulation. Okay, so due to this fluid accumulation, there is exchange of gas, it will not be takes place. That's why the person will be suffering from hypoxemia. So this is ARDS. Okay. The etiology of ARDS, it includes direct lung injury and indirect lung injury. Indirect lung injury means extrapulmonary injury to the extrapulmonary. Okay, that may leads to injury to the lung. So we can see which all are the causes that leads to indirect lung injury. First one, neurogenic causes. Next one, ischemia, reperfusion after lung transplantation or pulmonary end arterectomy. Then drug toxicity, transfusion related acute lung injury. Then acute pancreatitis. Then non-pulmonary sepsis like abdominal sepsis, urinary tract infection, bloodstream infection and others. And then severe traumatic injuries, fat embolism. All these are the indirect lung injury, indirectly affects the lung. Okay, so the indirect lung injury causes are neurogenic, ischemia, reperfusion after lung transplantation or the pulmonary and arterectomy, and cardiogenic problems also cause indirect lung injury. Okay, then drug toxicity, transfusion related acute lung injury, acute pancreatitis, non-pulmonary sepsis, abdominal sepsis, bloodstream infection and severe traumatic injuries and fat embolism. Direct lung injury means directly or pulmonary causes directly affects the lung and leads to respiratory distress syndrome. So here the cigarette smoking, then smoke inhalation, near drowning, aspiration of gastric contents, pneumonia, it may be viral, bacterial or fungal, then pulmonary contusion, ventilator induced injury. So in direct lung injury there will be cigarette smoking, inhalation injury, near drowning, aspiration of gastric contents, then pneumonia, viral, bacterial and fungal, then pulmonary contusion and ventilator induced lung injury. All this comes under the direct lung injury, directly harm the lung. This is the etiology of acute respiratory distress syndrome. Due to etiological factors, injury to alveolar membrane occurs. So that leads to damage to the microvascular endothelium and alveolar epithelium. That leads to injury to the type 1 alveoli cells and microvascular endothelium. And that also causes injury to the type 2 alveoli cells. The type 1 alveoli cells that cause increased capillary permeability. When the capillary permeability is increased, there will be influx of protein-rich fluid into the alveoli. There will be entry of protein-rich fluid into the alveoli. That leads to alveolar edema and interstitial edema. That leads to refractory hypoxemia. But in case of injury to the type 2 alveoli, here there will be decreased production of surfactant and decreased compliance of lung. That leads to alveolar collapse. Again, that leads to refractory hypoxemia. Ultimately, there will not be adequate gas exchange. Ventilation perfusion mismatch will be occurs. That leads to respiratory distress. So in the pathophysiology, due to the etiological factors, there will be injury to the alveolar membrane, and that leads to damage to the microvascular endothelium and the alveolar epithelium. So there are type 1 cells alveoli and type 2 alveoli cells are present. So in injury to type 1 cells, that leads to increased capillary permeability, and there will be diffusion of the fluids, protein rich fluids into alveoli. So what happens? There will be interstitial edema and the alveolar edema occurs. But in case of type 2 alveolar cells, there will be decreased production of surfactant. So when there is decreased production of surfactant occurs, that leads to decreased compliance of lung and alveolar collapse occurs. Both these factors together cause refractory hypoxemia. Then ventilation perfusion mismatch. So the person will be exhibit the signs and symptoms of respiratory distress. So this is the pathophysiology. The phases of ARDS. The first one, exudative phase. In the exudative phase, there will be cellular injury, especially the type 1 cells will be affected. Due to that, there will be capillary permeability, increased capillary permeability. That's why there will be edema and fluid accumulation. And here there will be reduced space for gas exchange, and the person will show the signs and symptoms of breathing difficulty, dyspnea, and there is need of assisted ventilation or the mechanical ventilation. That is the exudative phase or exudative phase of ARDS. In here there will be type 1 cells will be affected, and here there will be interstitial edema, and the person will show the symptoms of breathing difficulty. So that is the first phase, exudative phase. Next one, proliferative phase. Proliferative phase means here there will be proliferation of type 2 cells. Here what happens? Here there will be lymphatic drainage. So that's why the fluid will be, interstitial edema will be reduced, and recovery of alveolar capillary barrier. And patients feel better here, and there is sometimes there will be need of mechanical ventilation. So that is the proliferative phase. In fibrotic phase, the fibroblast proliferation occurs, increased fibrosis. So intraalveolar, lymphatic and interstitial fibrosis and capillary fibrosis occurs. So here what happens? Due to this fibrosis, there will be increased pulmonary hypertension. So when there is increased pulmonary hypertension, there will be refractory hypoxemia, and here there will be poor prognosis, and the person will be breath only by ventilator itself. Okay, he can't take breath himself. He always need ventilator support. So that is the fibrotic phase. Phases, that is exudative phase, proliferative phase and fibrotic phase. In exudative phase, here there will be exudate formation that starts from 0 to 4 days. Here alveolar and interstitial edema, capillary congestion, destruction of type 1 alveolar cells, early hyaline membrane formation. So all these features happens in exudative phase. Exudative phase means here there will be alveolar or interstitial edema due to increased capillary permeability and damage to the alveolar type 1 alveolar cells. And here early hyaline membrane formation. So that is the exudative phase. Exudation means edematous formation. Okay. Next one, proliferative phase. Proliferative phase starts from 3 to 10 days. Here increased type 2 alveolar cells. Here there will be increased type 2 alveolar cells, cellular infiltration of alveolar septum, organization of hyaline membranes. So here in proliferative phase, here there will be increased type 2 alveolar cells, and here there will be cellular infiltration of alveolar septum and organization. The hyaline membrane will be organized here in proliferative phase. Next one, fibrotic phase. Fibrotic phase that takes place greater than 10 days. Here the fibrosis of hyaline membrane and alveolar septum and alveolar duct fibrosis occurs. So here in fibrotic phase, it takes place more than 10 days, and here the fibrosis of hyaline membrane occurs and the alveolar duct fibrosis occurs. So what happens? There will not be adequate exchange of gas because the fibrotic changes occurs. So there will not be adequate the ventilation perfusion match. Okay, so mismatch occurs and that leads to refractory hypoxemia and ultimately leads to respiratory distress. So these all are the phases of ARDS. Stages of acute respiratory distress syndrome. So in ARDS, the stages are divided into 4, that is stage 1, stage 2, stage 3 and stage 4. Same like exudative, proliferative and fibrotic phase, here also the first one, in the stage first, here injury occurs to the lungs. So here there will not be any signs and symptoms. The person will be asymptomatic. And when you are assessing, you can see the respiratory alkalosis and normal chest X-ray findings. But in case of stage 2, here there will be vascular congestion and inflammatory response. So that there will be hypoxemia, lung compliance will be decreased and fibrosis occurs. When we are diagnosing, we can see that hypoxemia and bilateral infiltrate in chest X-ray. In stage 3, that is the proliferative phase, here the symptoms will be worsened. So the person will show the signs and symptoms of severe systematic inflammatory response syndrome. Okay, the person will have fever, tachypnea, tachycardia, then leukocytosis and inflammatory response and dyspnea, severe dyspnea, cough. All these features will be present in stage 3. And hypoxemia will be worsened and decreased lung capacity, and ultimately here there will be organ damage. In stage 4, there will be lung remodeling. Here multiple organ involvements and complication can be occur, and hypoxemia may be worsen and multiple organ damage occur as a complications. So in acute respiratory distress syndrome, it is divided into 4 stages. Stage 1, lung injury, there is no signs and symptoms. The patient is asymptomatic. In stage 2, there is interstitial edema or increased capillary permeability. So what happens? There will be signs and symptoms of hypoxemia and decreased lung compliance. In stage 3, that is the proliferative stage. Here there will be signs and symptoms of systemic inflammatory response syndrome. Okay, that will be occurs. So there will be tachypnea, tachycardia, fever and all these features will be seen. And stage 4, here there will be lung remodeling. So due to this lung remodeling, there will be multiple organ damage and complication will be occurs. So remodeling will be mostly it is fibrotic changes, right? So the ventilation perfusion mismatch occurs, and the hypoxemia will be worsened, and ultimately the organs will be damaged. So that is the problem here. The clinical manifestation of ARDS include early signs and late signs. Early signs, here the person will have restlessness, dyspnea, low blood pressure, confusion, extreme tiredness, changes in patient's behavior, mood swing, disorientation, changes in level of consciousness. If pneumonia is causing ARDS, then client may have cough and fever. So, in clinical manifestation early, the person will have the restlessness, dyspnea, blood pressure may be low, and confusion. The neurological symptoms will be present. The person may have confusion or disorientation may occur, or level of consciousness will be affected, and mood swings can be seen. So changes in the behavioral pattern because it affects the different organs. Okay, multi organ will be affected due to the ARDS. So in neurologically, these all are the signs and symptoms. And in case of pneumonia, the person will show the symptoms of pneumonia also. That's why the person will have cough and fever. Next is the late symptoms, late signs and symptoms. Here, the person will have severe difficulty in breathing, or labored breathing, or rapid breathing, and shortness of breath, tachycardia, cyanosis, diaphoresis, uh, thing, pink frothy sputum, metabolic acidosis, then abnormal breath sound like crackles, decreased PaCO2, that with respiratory alkalosis, and decreased PaO2, partial pressure of oxygen and partial pressure of carbon dioxide. So usually in moderate phase there will be tachypnea, tachycardia, then chest retraction, then sensation, or the disorientation, or the person's ability to identify the time place person. Okay, it will be affected. Then there will be bilateral infiltration can be seen in chest x-ray. So in late signs, here there will be the dyspnea will be exaggerated, and tachycardia, cyanosis mainly due to hypoxia, and the sputum production will be increased, and metabolic acidosis also can be present. Then due to inflammatory response there will be crackles. The respiratory alkalosis, that is mainly due to decrease partial pressure of carbon dioxide.